My name's Mahesh. I'm a scholar from Australia. It's my pleasure to introduce the next speaker, Dr. Samir Sinha. Dr. Sinha is a senior scholar from Canada and is a pioneer in the geriatric field. As Director of Geriatrics at the Sinha Health Systems and University Health Network in Toronto, Dr. Sinha has worked to improve models of care for the elderly. His innovation and optimization in the field of healthcare and geriatrics resulted in him being named one of Canada's top 50 most influential people by Maclean's magazine. Today he'll give a talk entitled On Becoming a Geriatrician, Health Advocate and Effective Ship Disturber. It's my pleasure to introduce Dr. Sinha.
So thank you very much, everyone. We're going to go from genomics to geriatrics, and because this is one of the newest specialties of medicine, being only a few decades old, I'll also be providing you a little bit of a primer today on what it is that I do and some of the implications this has when we start thinking about innovative ideas and taking them from actual concept to actually trying to put them in place and dealing with that on a larger policy landscape as well. So of course, we all have a similar story where, when we arrived at Oxford or wherever the journey started for many of us, my journey before Oxford was where I was training to be a physician. That's what I wanted to do, and that's how I thought I could make a meaningful difference. And I thought I was going to be a gastroenterologist. This was an exciting specialty of medicine at the time. I had a great mentor, and I was doing a lot of really neat research in that area. But I also knew that I was interested in working with vulnerable populations, and it was my mentor here on my very first day in his study at All Souls College where he said, "You have an enormous opportunity with this Rhodes Scholarship. This is part of the reason why you applied was because you want to be a health advocate. This actually gives you a voice. You say the word Rhodes Scholar, it does actually open doors for you. The question is, you better have something to say after that or you'll be kicked out of the house," right? But the opportunity, he said, was, there are many different vulnerable populations in society, but have you ever thought about working with the elderly? Now, I hadn't really thought of working with the elderly much at the time, mainly because, as a society, we don't tend to value aging, right? We all want to live, we want to live forever, but we also want to live young. We don't really think about growing age in the most dignified way, and so why would anybody like myself who's a young physician want to dedicate their career to caring for a segment of society that we don't actually appreciate? But he said, this is a good area, why don't you try it out? And I actually got addicted, because when you start actually learning about the issues of aging, how they reflect how we are as a society, how we view ourselves, how we view others. But when we start actually thinking about areas beyond that, about the demographic implications of an aging society, you start realizing there's a huge amount of opportunity ahead of us and an incredible amount of work ahead as well. When we start thinking about aging, there are different terms that you start hearing. Often the term that we hear a lot in the newspapers is this idea of an aging tsunami, the demographic tsunami that's happening. Someone earlier today said, geriatrics, that's kind of a cool career, that you thought about when you're here at Oxford. You must have been a bit of a futurist, right? But I also think that the idea of using terms like tsunami are very problematic in this field, because tsunamis happen by surprise. Like that's the very nature. They come at you without any warning. They lead death and destruction anyway. And even the idea that people thought that I was quite the futurist back in 2000 thinking about a career in geriatrics. Well, if anybody's heard of the baby boom, really the reason why we're so worried about an aging population, why people are using terms like, could the elderly bankrupt our country, right? How are we going to meet the needs of an aging population? They're overwhelming the NHS, right? Instead of calling older patients, we often use terms like bed blockers, for example, other pejorative terms. So there's a huge amount of negative connotations around the elderly, but I think it also reflects the fact that we haven't actually been thinking a lot about their needs. We haven't actually been thinking about how as a society we're aging, and how a lot of this reflects very poor planning for a long period of time when we were more excited about other shiny things. The key where I like to focus on the term triumph is when you actually think about what aging has really represented for our society, even over the last 100 years. If you look at our life expectancy, and I'll give you the statistics in the United States, but if you look at life expectancy back in 1900, in the United States, it was 47 years of age, okay? 47. In the Roman Empire, it was about 35 years of age. Okay, so over 1900 years or whatever, we didn't make a huge amount of progress. But then you've heard, Dr. Bell mentioned earlier today, just about all the huge changes that have occurred just in the last century alone that now mean that life expectancy is generally in our high 70s, early 80s. And so when you think about what was the greatest accomplishment of the last 100 years, some people say we put a person on the moon. I think the fact that we almost doubled our life expectancy is terrific. Of course, the key is that we're now no longer going to likely die of our first heart attack. Maybe the 8th one will kill us, right? We're more likely, if you get cancer, you might get cancer, but more and more people are cancer survivors. And so, of course, as you graduate to those older and older decades of life, you now be meeting new areas, such as dementia, for example, where we now know that if you live into your 90s, you have about a 40% chance of living with dementia. So these are whole new areas that we've never really thought about, and the implications that these new diseases, these new experiences that we're having are significant as well. And so that's, you can imagine after 4 years of studying the issues of aging, thinking about how governments are thinking about this strategically from the way we deliver healthcare, the way we think about policy, how do we actually treat the elderly as they become the fastest growing segment of our population? There clearly was a lot of work to be done. And that's where I firmly decided after my time at Oxford that this is what I was going to dedicate my career towards. Of course, when you think about healthcare, that's obviously the field that I'm in, and that's what we're talking about today. This is just spending in Ontario. This is the largest province in Canada. 1/3 of the Canadian population lives in central Canada in this province, and this is actually spending on healthcare by age. So billions is your vertical axis, and your age is your horizontal axis. And you can see, in an appropriate way, I don't think anybody would look at this and say, well, that's just an incorrect way to spend your dollars, if you will, because really, we're spending more money towards the later years of life. And that makes sense. As we get older, we're more likely to experience health and social concerns, and this is where we'd actually encounter issues, and this is why we'd have to spend money later in those years of life. But of course, this is the concern, that over the next 20 years, our population in Canada and Ontario that's 65 and older is going to double, and the number of people who are 85 and older are going to quadruple. This is the demographic challenge we have. And of course, when you think about spending on healthcare, just to meet the needs of an aging population with the same healthcare system we have today, we estimate that that's what our spending curve is going to look like. And you can see that right now when we spend $50 billion on healthcare in Ontario alone, we're going to have to find another $24 billion just to meet the needs of an aging population. But here's the crux, because when we start thinking about how we spend our dollars looking after people like my former patient, Mr. W, we realize that these are the typical patients we actually now have in our healthcare system. But 50 years ago, when we founded Medicare in Canada, our version of our universal healthcare system, the average Canadian at the time was 27 years of age. Right? 27 years of age. So you can imagine that when we created our healthcare system in Canada, what is universally and fully covered are hospital services and physician services. We never thought about covering things like home care or nursing home care. We didn't think about making drugs universally accessible for the population because if we're a bunch of 27-year-olds, we don't really think that we'll need those sorts of things. And at that time, life expectancy was only 67 years of age. So we weren't even thinking about issues like dementia because we didn't have a large segment that was actually living with those issues at the time. But one thing I often like to say is our patients have changed and our system hasn't. And this is one of the patients that I have held always very close to my heart because here's one guy who really helped me understand that no matter how much policy and how much stuff I was reading, when you actually face one of these individuals and have them go through our current healthcare system, you realize how dysfunctional it is. So Mr. W, who is he? I mean, here he is in this picture, right? He's living in his natural habitat here, sitting in his big comfy chair in the apartment that he was living in for about 26 years at that time. People would think, well, if he's 100 years of age, at the time of this picture, that probably he has a 50% chance of having dementia. But you can just look at the windowsill there and you'll see his 2 Rubik's Cubes, which I used to joke I could only get them to look like that if I never touched them, right? Or if I changed all the stickers, right? But here was a guy who was struggling to live independently. He had all these wonderful acronyms, on his past medical history list: COPD, CHF. He had quite bad arthritis as well. And by the time he reached his late 90s, he was becoming increasingly homebound, meaning that this gentleman could no longer just easily get out to his local GP practice to go see his doctor. So for him, as his world was closing in on him, he was still very cognitively intact, wanted to live at home. But the only way he could access health care was actually by calling the ambulance and going to the emergency department. He became a very, very expensive user of the healthcare system. And when I met him in September of 2010, 2 weeks into my practice as a geriatrician in Toronto, I met him on his 7th admission to a hospital at that time. Here's a guy who's struggling to live independently, and yet he comes to our hospital when he has a pneumonia. And the challenge with our hospital was that we were all trying to provide care for him over a long weekend. And the challenge is that we almost killed this guy, because by Monday morning, this guy who was perfectly functional on the prior Friday, walking around with his walker, when he came to the hospital because he had a pneumonia, he wasn't feeling very well, all of a sudden we tried to do a lot of things to help this gentleman. But it was actually a lot of the things that we were doing that would work perfectly well for a hospital system built when we were 27 years of age on average, clearly didn't work well for the 100-year-old. What do I mean? Well, there's a lot of great literature now looking at something we like to call the hazards of hospitalization. Okay? And you take a person like Mr. W, who other than, having these chronic health issues and being a little bit more limited with his mobilization, he would walk around his home with his walker. But this is a guy who was able to actually get around and kind of live relatively independently in his own house. But of course, the challenge with being an older person is that older people have less functional reserve. They have less physical reserve. And as a result, whenever we get ill, we all know that we actually start to feel a bit weaker at the time. But you can imagine for an older person, if they actually feel weaker, that actually might be the difference between them being able to get out of a chair, stand from a sitting position in a chair independently. These are some of those basic things we call your activities of daily living, things that you probably did in this order in this morning. You transferred from a lying to a standing position. You walked over to the bathroom, you toileted yourself, you bathed yourself, you dressed yourself, and you ate something. These are what we call the 6 basic activities of daily living. And we know that older individuals, especially with multiple chronic health issues, struggle with one or more of these on a daily basis. And for Mr. W, his challenge is whenever he got ill, he actually lost the ability to transfer. That's why he fell at home. That's why his son, who lived on the other side of the country, got concerned and thought he needed to go to the hospital on a Friday night. Of course, you imagine hospitals on Friday nights or on the weekends. You've heard about the issues of the 24-hour NHS in Britain now. This is the time when we fully staff up, ready to meet our older 100-year-old patients who are coming to us on a Friday night. But here is a gentleman who's already functionally impaired, had a functional injury, and then all of a sudden he came into our hospital. And this is the challenge. Lots of great research has shown that our hospitals that were designed, if you will, for 27-year-olds don't work well for 100-year-olds, or really most of the people who are 65 and older. And why is that? Well, first of all, they're very hostile environments. We've actually engineered hospitals to be very efficient and effective places for clinicians to a certain extent, right? So how many of you were up at 4 a.m. this morning? Okay, one person. Drew was up at 4 a.m. this morning, right? Well, the key is, first of all, as we get older, we don't actually sleep as well. Okay, so that's a problem, first of all. And hospitals are not very quiet places. They're quite noisy places, so it's hard to sleep. But imagine now I'm going to wake everyone up at 4 a.m. That, at Mount Sinai Hospital, is when we're allowed to start waking you up so we can get your blood work so it can be all ready for the clinicians when we come in at 8 a.m. in the morning, right? So you imagine that these are places where the regimens have been made to work for the clinicians, not for the patients. We also strip people out of their clothes. We put them in hospital gowns. And for many of us who like to express ourselves the way we wear our clothes, this is problematic, right? The other issue that we also have is that, in Toronto, which is the world's most diverse city, people have, Mr. W had a very long Polish name, but people could barely pronounce it. So they would just call him wonderful terms at the age of 100 that he acquired, like honey, sweetheart, and dear, right? Someone might even pat him on the head and say, oh, you look cute, don't you? really something that we don't really look forward to, receiving that level of care. But then there's the challenges, is that bed rest and immobility. It's something that we tend to do when we get sicker, when we actually lie in bed. The problem is that every day that an older person is in bed, they actually lose percentage points of their muscle and bone mass, which translate into function. Every day you're in bed, you lose 5% of your function. This was why when Mr. W on Friday morning was able to ambulate around his home with his walker, by Monday morning he actually lost enough function that he was actually at what we call a two-person assist. 2 nurses had to lift him up to take him to the bathroom. That's how rapidly he lost his physical functioning. And of course it was interesting when I saw him Monday morning for the first time, watching all the comments that started appearing in his chart, likely no longer going home, destination, nursing home, right? Well, we got him home for 5 more years, okay? But the point is, you can actually start seeing that the hospitals themselves can be challenging places for older adults, and this can lead to issues of complications in older adults, which lead to longer lengths of stay, and this can lead to more issues of confusion, depressive symptoms. 23% of older adults actually talk about the hospital being a depressing experience, and 23% actually have depressive signs and symptoms. And of course, if people are losing function, if we didn't actually make things better for Mr. W to regain his physical functioning so he could return back home, imagine where would he have gone? Well, not back home, probably to a nursing home, which is not where he wanted to go. So Bob Palmer, who actually created this schematic, he's one of the fathers of hospital geriatric medicine, did this schematic in the late 1990s, and you can see it's a perfect recipe where it has loads of examples where none of us in hospitals, none of us in healthcare are trying to cause harm to older adults or our older patients, but it's the things that we were doing that worked well for 27-year-olds clearly needs a different approach, and this is clearly a recipe that we can actually mess up to actually ensure that older people do better. So of course you can understand that when the majority of hospital days in Canada, 60% of the hospital days in Canada, I would say it's probably a similar number of days in the NHS, are actually accounted for by older adults. They are now the #1 customers of our hospitals, yet they only actually represent 16% of our current population in Canada. And you can see that we have wonderful editorials like this that come up all the time. Our hospitals are unprepared for our aging population, et cetera, et cetera. The key is we have a huge disconnect, and this is where I like to say the patients have changed and the system hasn't. So, Mr. W's admission to hospital was really one of those opportunities where we said we really have to do things differently. There were so many missed opportunities where if we just didn't do certain things to him over time, if we actually engineered or re-engineered his care differently, if we were actually a hospital that prioritized the care of the elderly, could we have actually had a significantly different outcome? And could that actually make our hospital run more efficiently as well? And so this is where this concept of the elder-friendly hospital came from. And my colleagues and I, we decided to actually come up with a cool name. We said, well, we're going to do something. It's got to have a cool name. So we came up with the idea of ACE, right? ACE, that's a cool name. And we called it Acute Care for Elders. It's our strategy, right? And we really had 4 basic principles. We want to redesign the way we provided care and say, can we enhance and improve upon current service models that, again, were developed for a much younger population. We want to shift our traditional thinking because most of our organizations, in fact, until I arrived in Toronto, there was no Ontario hospital that was actually prioritizing geriatric care, even though 60% of our hospital days in Ontario are accounted for by older adults. Baffled my mind. If this was the corporate world, our #1 customers would be the elderly, right? But we didn't view this, even that just showed how much of a blind spot we actually had. And the key is what we want to do is, were there things we could have done early on? When we talk about precision genomics, this is kind of where we get into precision geriatrics. Were there things that we could have identified early on with Mr. W where we would have actually immediately changed the entire course of his care because we actually understood that there were opportunities to act differently to actually maintain his independence? And then finally, could we focus on making sure that whatever we did do, we were monitoring what we were doing, we were evaluating what we were doing, and seeing if we could actually change that around. And so this is the model that we started building. We really started to get together as colleagues and said, wait, if we're going to build this, what are the elements we need to think about? So we started immediately reaching out. Again, I was based as the head of geriatrics at a hospital, but we immediately started reaching out with our community partners, and we started saying, what are all the community models that we can actually build? Because all of our patients actually emerge from the community. So could we actually do more upstream and interesting things at that level so that we could actually help people like Mr. W? So we started a home-based primary care program where for people like Mr. W who are homebound, we actually go to him. We do house calls for people like him so we can deliver the care to him. We even went more upstream recently, and we started a community paramedicine project where the head of the paramedic services in Toronto, he said 60% of our calls in the city of Toronto are actually for the ambulance are actually from older adults like Mr. W. But we can actually start using our data. We can actually start saying who are the hot spotters, and then we've actually trained 4 paramedics now who actually go ahead and meet up with these patients in a non-urgent situation and actually provide counseling and support and linkages to actually help them not come to the hospital. And we've reduced the repeat 911 calls in that group by 49%. So then we've actually started working on that again, that identification, that precision geriatrics, if you will, by actually identifying, screening every single patient in our emergency department. 6 simple questions to identify, are you a Mr. W or are you a 95-year-old marathon runner who just happened to slip at home and break their hip, right? Who are you, and are you a person who needs more of a geriatric approach to your care, which we start establishing with nurses and other folks right in the emergency department. Then if this person needs to actually come into the inpatient setting, what are all the different things that we can actually do? So we've created things like ortho-geriatric units, ACE units. You can tell we love that name, ACE. We've also started engaging volunteers by training them specifically to work with the frail elderly to help them with their recovery as well. And then finally, we've also looked at what are the outpatient and community models that we can do. And it's by doing this continuum, by building this continuum of care, we've really just tried to say, what are the problems with our system, right? Because our system wasn't designed for these folks. How do we re-engineer things? We haven't blown up the hospital. We've just actually made it work better for older people and really tried to, in a local way, in our local region, try and make healthcare a little bit more easier for those older adults and the people who are trying to help them. So of course, when I talked about that important focus on monitoring our data and looking at our outcomes, we were quite relentless in doing this, and we were actually very lucky because we had an incredibly good IT team that was able to help us crunch our numbers on a regular basis and look at it. Now here's our challenge. In downtown Toronto, our population of people in the last 10 years has actually doubled in numbers. And in the last 5 years, the number of people living in downtown Toronto has actually increased by 60%. So the number of older patients coming to our emergency department, being admitted to our hospital, it's kind of like trying to re-engineer an airplane at the same time when more and more people, are coming on board at the same time. So the number of older people that we're actually seeing through our hospital doors has increased by 53%. But at the same time, we were able to decrease our lengths of stay for older patients by 26%. And while we were able to get people out quicker, we were able to actually get them home and help them stay at home longer by actually reducing our readmissions by 14%. At the same time, we re-engineered care. We tried to make sure that we weren't actually doing negative things to older people, like using urinary catheters unnecessarily. Those catheters go in, and those actually become single-point restraints. They limit mobility, and remember how mobility is a big issue? And so by doing that, we actually were able to lower our use of urinary catheters by 50% in our hospital. We also try and make sure that we don't immobilize our patients. So one thing that we used to joke about is we're no longer competing with the Four Seasons hotel chain, right? We're no longer serving breakfast, lunch, and dinner in bed. Because by doing that, naturally in hospitals, we were keeping our patients more mobile. So now we actually have orders in our order set saying everybody has to be up and chair for meals. I mean, we're talking about simple innovations which are really just applied common sense, but by doing these sorts of things, we decrease falls by 66%, and we decrease pressure ulcers, bed sores, by 93% in our hospital. We also were able to actually make our patient satisfaction rating now for our 65 and older patients up to 99%, no longer really reporting those depressive symptoms, if you will. And here is the best part. Why our CEO loves this is because at a time when we were actually not receiving any budgetary increases, in our best year alone, we were able to save $6.7 million just by delivering more efficient, effective care for older patients. So this was our magic of ACE. And the nice part was that now we're actually seeing support from the federal government to help hospitals across Canada in other jurisdictions as well, trying to implement these approaches before. So of course I made it sound really easy, right? This is the easy thing to do. And then of course in the middle of all this work, being an academic physician in downtown Toronto, who's interested obviously in models of care and re-engineering the system, I was requested by the Minister of Health, who works at Queen's Park, which is our legislature down the street, to say, could you actually recreate some of these benefits for the entire population of Ontario? We actually need an aging strategy because, heck, our whole population's aging and we actually need an approach. So I got tasked with writing this in the middle of my day job. This is a 234-page blueprint. The only request she had was that I actually have a positive title, so Living Longer, Living Well. Because again, when we talk about aging, we often talk about it in a negative way. But you can see that aging and improving what we do goes well beyond the hospital. It's not just about improving primary care, home and community care, long-term care. It's also about thinking about how do we actually ensure that our communities are age-friendly? How are we making sure that our environments are designed so that we can get across the street in enough time, especially if we have mobility impairments? How do we make sure that there's good transit services so that we can actually even travel more easily, and making sure that our buildings are more publicly accessible if we have hearing or visual difficulties? We heard a lot about the importance and the idea of Wellville. It's not just about older people aren't just interested in saying, help care for me when I get sick, but what are the things that I can do to stay healthy and well? And that starts much younger than 65. But even at the age of 65, there are many things that we can actually do to make a meaningful difference. And this is where we have to start thinking about aging, not just at the level of our hospitals, but again, how we actually think about issues at our society level. At the same time, trying to look at issues like ageism, thinking about the needs of caregivers, it really requires a fundamental way in which we try and re-engineer and think about this. But this is one of the greatest learning experiences I had, because you can hear that working in a hospital environment, I was working with my colleagues. I actually chose the environment I worked with because these were the things that I wanted to do, at the local level of my hospital with our ACE strategy. And I was luckily working in a fertile environment where, it wasn't easy work, but I was working with colleagues who were like-minded, so I could choose that. But when you start thinking about how are you going to retool an entire province and start thinking about different recommendations of how you move that forward, you start finding the challenges of, it's one thing to write a report. That was the easy work to do. It's another thing when you make 166 recommendations to government and across 8 different ministries, or how are you actually going to get that implemented, especially along a political life cycle that only lasts 4 years at best, right? This is the challenge when you start thinking about how policy can actually start eating strategy or innovation for breakfast, and why it can be very problematic. The other thing I realized was at a federal level, you'll know that we have a new government in Canada at the federal level with Prime Minister Trudeau. And this is interesting because after the work that we did in Ontario, they started getting interested in the idea of a national senior strategy. But this is one of these interesting lessons I learned was the government never actually ran on a policy of a national senior strategy. And I was really disappointed because I was saying, here are the ideas. In fact, I actually got a grant from the Canadian Institutes of Health Research to say, what would a national senior strategy look like? So I said, here's the book. I've actually written you one with a research grant. You can implement it. It was actually written at your level, right? But they never really took it on. But that's fine because you realize you don't need a government to actually tell you whether or not you can write a strategy. You can write a strategy. And the fun part we actually had was we actually created a national movement. We got all the major associations around to even create a website called Demand a Plan, nationalseniorstrategy.ca. And the nice part is now the federal government has actually been implementing many of the recommendations in here that are, again, backed by evidence. So it's looking at approaches like this in terms of thinking about how you can do this. But this gives you a bit of a flavor of a bit of the journey I've been on for the last few years in terms of how I've been starting to think about this. So now to the final part, is just giving some words of advice and wisdom in terms of thinking about different careers, different ways of thinking about this, and different ways, because I've been very fortunate. I had great mentorship when I was here at Oxford. I had great mentorship before. And I've had the opportunity of finding really, really good colleagues that I could work with. And now I always get people coming to me and saying, wow, how did you get to be the government lead for seniors in Ontario? Like, did you apply for that? Like, is there any training that you go for that? If I did what you did at Oxford, is it that I win a Rhodes Scholarship and then I do a master's in history and a doctorate in sociology? Is that what I have to do? And I'm like, there is no one right path, right? As many of us will realize over time, when we look back, it's like, wow, that looked pretty good. But you realize that our decisions on what we study, our decisions on what we do, they often vary by life's circumstances, what happens. It happened to me in the fact that my government role happened because the media really liked what we were doing. They were really excited, and then I had a minister in a government who basically wanted a fresh young face, preferably who was of color, who actually knew something about aging. And when they found out that I was gay, they thought bonus, right? Like, oh my God, this is amazing, right? I remember when the chief of staff was like, you're gay too? Oh my God, So, but I'm going to be honest, right? So there's actually no one right way in which you actually go this loop. So for any of you who are thinking, and I've had some wonderful chats, over the course of the day so far about like, what should I do it this way? Should I do it that way? There's no one right approach. But I'll give you some pieces of advice now in terms of things to consider. So first of all, one of the things I learned, and one of the reasons I enjoyed starting my studies at Oxford with a master's in history, was because basically I spent the first year of my time here actually studying the history of the NHS in terms of its approach to the care of the elderly. And that was a fascinating, thing to study, because all of a sudden you realize, how the NHS was created. Why do we have services the way they are? What is the local experience? So that whenever you're actually then tasked with actually saying, okay, here's a problem that I need you to solve, if you don't understand the background, if you don't understand the history of what happened, what worked, what didn't work, why didn't it work, it's really going to make your tasks ahead really challenging. So whatever task that you get asked to do, when you're thinking about, when we were talking about genomics and how do we actually start looking about getting people to share data and doing that, we have many other examples of doing that in other ways. And the question is, what can we learn from those experiences? What are different approaches that we can do in similar ways? And so I always emphasize to anybody, before we ever start anything, is there a history of doing this before? What's the landscape? Who are the allies? Who are the enemies? What worked well? Why didn't that work well? Because if you don't do your homework, you're gonna be challenged. The next thing is you can't boil the ocean. I think whenever we take on any task, we want to solve every single problem at the same time, right? We're saying, that, with this issue, I want to solve this, I want to solve this. With my strategy, I said, okay, let's solve everything in Ontario. And you realize you can't get everything done on day one. So how do you start being incremental? How do you start being strategic? I was just in India, where geriatrics is really a nascent specialty. It's less than 10 years, and now the government's actually starting to create centers of excellence in geriatrics. They have 5, and the goal is in the next few years they're going to do 20. And I met with the newest grad who's come out of the main school in Delhi, who's now the first geriatrician in Nepal. And he's looking for a mentor. And I'm like, I will happily be your mentor. And he said, where do I start? And I'm like, he said, I want to do something here, but they don't want to talk to me. I said, well, then ignore them, right? I said, because you're telling me that this person wants to work with you, start there, build a success, right? And then you can go from there. But I think it can get very overwhelming if we always think about, let's try and do everything at the same time. Always think about those incremental benefits, because especially if you're new to an area and you're building your reputation, it's always an opportunity to say, what bite-sized things can I achieve? Because that success will breed more success. People will then, maybe the person didn't want to talk to you because they weren't sure whether you're a person who talks a lot or a person who can actually get things done, right? So there are a number of reasons why you may face resistance at the beginning, but the opportunity is try and figure out what are those things you can tackle. Never lose an opportunity to engage others, right? So Mr. W is a classic example. He was a patient I took care of, and then 3 months after he left the hospital, these pictures were taken at his home by his family doctor, his new family doctor, who's a house calls doctor, who's also a very gifted photographer, who said, well, he engaged me by saying, I'd like to photograph you as well while you're doing the home visit. And Mr. W, we used a wonderful opportunity where I was doing his home visit to tell him more about what I was doing. He was a very intelligent guy. guy. This guy was both trained as an architect and an engineer in Krakow, Poland, and he actually oversaw the rebuilding of the old historic center of Warsaw after the war. He had an incredible story and legacy, and he was very interested, as you can see, how well-read he was about what I was doing and what I was up to. And he's like, well, how can I help? I know I'm 100, well, in the UK I'm 101 by that point, but he said, how can I help? And so he actually became the poster elder for the provincial senior strategy, right? And we actually started in a television commercial together, and he was actually in various news, and he loved his new media career after the age of 100, right? But again, it's the ways in which you can engage others, right, in terms of thinking about that. But remember, when you're engaging others, you have to also kind of try and think about, and this is a really good framework that someone gave me, think about that balloon over their head and this little balloon that has some words in it, and really it's the acronym you want to think about is with him. What's in it for me, right? What was in it for Mr. W? Well, he was really interested in seeing that other older people actually had better experiences in hospital. That was him. He's like, I'm 100, I've done a lot of things, but I haven't had a media career, so I'd love to do this too, right? I mean, that was what was in it for him, but also, it's also thinking about what's in it for your colleagues. When you're actually start trying to build things, right? Not everybody's going to be aligned on the exact same things. Not everyone's going to have the same mindset as you, but if you find that plane in which you can align, then it can be quite amazing. Working with politicians, working with government bureaucrats, you started learning about how folks think. And I know that for my political colleagues, I started learning about how I had to change my communication style as election cycles approached. I remember it was January 3rd, it was about 6 months before the next provincial election, and I was meeting with the minister's chief of staff, and we were having a briefing, and they're saying, so what are the next things we want to work on? And I said, do you want to hear more politically announceable ones, or do you want to hear more boring, drying ones? They're like, political announceable ones, right? And it was kind of thinking about how they thought and speaking that language, because by learning to speak in the language, understanding what's in it for them, we were able to move on certain things more effectively at different periods of the time. Always working with others makes things easier, right? Sometimes, we always want to work, on our own or say, well, if I just do it myself, then I'll get all the credit for this initiative, right? But amazingly, when you spread the workload, you can get more accomplished, and especially geriatric care, there's so many issues that you gathered were at hand that really, by working as a team, you share the workload, you can get more done. So always think about opportunities where you can engage others, because when you engage others, it's less lonely. You got more friends to have a beer with at the end of the day when you want to bang your head against the wall. And it just makes it a much more enjoyable experience. Be wary, right? There are going to be people in your life who are going to want you to succeed, i.e. yourself, probably your parents as well, right? But sometimes you're also going to encounter other people who don't want you to succeed. And this is one of those really interesting things that was a real hard lesson for me to learn early on. Anybody who knows the academic medical landscape of Canada knows that the University Avenue hospitals can be very treacherous places for a young clinician, or a young clinician kind of advocate, if you will. But I had lots of good allies, but every once in a while you've got people who just don't want you to succeed. And this is a picture of, does anybody know what this represents, this classic phrase that someone taught me? Has anyone heard the term crabs in a bucket? Is that what you're going to say? Exactly. That's exactly. And so it was one of my colleagues who said there's this great term, she was from Jamaica, and she said we have this wonderful term called crabs in a bucket, right? The idea that people are always trying to pull, why when someone's trying to actually reach up and achieve something new, sometimes, and it was amazing what, I would encounter sometimes, right? Sometimes you'd actually hear, people would start rumors about you, crazy things. One person, because it was getting a lot of play in the media, someone actually started a rumor, it was a CEO of another hospital started a rumor that I hired my own professional publicist. Right? And I'm like, okay, why do you have time to start rumors like this? And why are you trying to do this? But to me, that was really upsetting. I'm like, why would they say something? They're so mean, right? And then my friend would say, okay, entrance of the hospital, 20 minutes, we're going for an emergency beer, right? And that's why you want to work with others, right? And have those allies, because again, they'll say sometimes people won't want to work with you, won't want to help you out. But you know what? The key is, as long as you're doing the right thing, as long as your heart's in the right place and you're actually trying to do the right thing, and you will make mistakes along the way too, the key is just remember that sometimes that happens, so that's why it's good to build those alliances with people who can help you stay in the right. And remember, you are going to make mistakes, and your failures are an incredible source of wisdom. So use those opportunities as opportunities to learn, right? Because if you fail and you don't actually learn from from that mistake that you made, you're doomed to repeat it as well. But again, there's often a lot of things that you can get. I can think of countless times I failed, probably hundreds of times, in the last 5 years alone, where again I say, wow, I'm going to course correct and not do that again. Or if I actually did it a little bit more this way, I could have actually had a better outcome. So learn from those opportunities. Here's one that might be a bit controversial. I was thinking about writing this and I thought, wow, I'm standing in a room with lots of heads of state around me, right? But for my perspective from that of a healthcare advocate it's the idea, and I actually have lots of former heads of states who are my patients who give me this advice, but I think mainly it's because they fear that if I become a politician, I'll stop taking care of them. So it's the idea that be political, but try to avoid a political career or problematic alliance. This magical dream that if I run for this party and we get elected, then they'll also make me the Minister of Health and I'll get to change everything, right? It's a nice idea. And sometimes it does happen, but many times that doesn't happen, right? And the question is that once if you do follow a political career, the challenge is it might actually limit your ability sometimes to actually get things done. I like this idea that while I was appointed by the minister, they were, one of my big worries, and one of the best pieces of advice is do not be aligned with the Liberal Party, though. Everyone's going to start pigeonholing you, say, oh, you're a Liberal. So now I have two other political parties that if they get in power, they're no longer going to talk to you. So I've been very, very, key, and this is actually, former premier from a different party who really gave me that advice, help them out, they appointed you, but don't be their political lackey. Because otherwise, it's going to be hard for me to get you to work for the Conservatives or for the New Democrats. So by staying neutral, you can sometimes be more effective and you can sometimes be more influential. The other aspect is that when you're actually trying to do policy change or other things, again, if you think about, do you want to be seen as a paid spokesperson for company X or Y? You have to really think about that brand that you're creating and the work that you're doing and how it can be challenging. Here's another piece as well, is that when you hold power, it pays dividends to be gracious, generous, and kind. This is really good advice that was given to me early on. Because the key thing is that when you're actually in these situations where you actually can wield power, you can be really helpful. So some of those folks who've said very mean things to me, I still greet them with a smile, I still shake their hand, and I still offer to help them out whenever they can. Because who knows where I'm going to be some year from now. And if I'm actually, if I need to be on the receiving end of their support or help, I hope they remember that generosity and pay it back as well, right? And there are often many things that you can do. And often in some of these situations where they become very political or helpful, and sometimes just things get absolutely ridiculous, I love going and apologizing and just taking responsibility for everything and say, you know what, I don't know what's going on here, but I apologize. I take full responsibility. Say, but that wasn't even your doing. You didn't have it. I'm like, I will happily take the blame for this issue, because by doing that sometimes it helps diffuse a situation and it helps remind people that, again, that generosity can be important as well. Last thing is, it's not about you, it's about the issue, and try to lead by example. This is perhaps one of my favorite photos, and this was actually one of the lead photographers for our national newspaper, the Globe and Mail. He wanted to come with me on a day of house calls, and he wanted to see, I want to see what you do. What's it like, being a doctor in the house, right? And I love this picture, and this actually won the National Photography Award back in 2012. And unless you can recognize my bum, you can't see me. And that's the point here. This is not about me. This is about the issue of people like Stephen, who was 92 at the time, being able to try and remain independent at home, because for him and his wife, this is where he wanted to age in place. He wanted to die at home, and we gave him that gift. And that's what the focus is on. It's about Stephen. It's about him maintaining his independence, but us being there, in the background, providing that support. You will get tons of credit along the way, I'm sure, but if that's what your goal is, it's about you getting credit, then sometimes that can obscure things and actually lead more people to want to try and pull you down if they feel more jealous of you. When they see this is not about you, this is about the issue, it's hard for people to not be your ally. Finally, take time for yourself, right? There's a lot of, this is a lot of work that I've been involved in the last number of years. I've been hearing about a lot of the great work that everybody's been involved in here, and it can be all-consuming. And the key is, your CEO, your boss, whatever, is never going to be one to kind of say, well, hey, you should take a few weeks off of vacation. They'd love for you to stay around and just be more productive and put out more papers and do that. But I was just, I'm on a 3-week tour around the world at the moment, and I was just in Singapore doing some work with their government. But then I had a 3-day blip, and I thought, you know what, I want a little holiday, and I want to go somewhere where I can just go and discover a place new. And so this was taken in Yangon, Myanmar. And it was a wonderful time where I could actually just be on my own, turn the phone off, and actually just go and learn about another people, try some really cool food, and take a little bit of time to relax, right? So just always remember that you have to think about yourself first, because other than, yourself, you are your greatest champion, and you need to make sure that you keep yourself recharged. Otherwise, you're going to burn out too quickly. So one of the nicest things about being a geriatrician is you can be a more useful member of your family. Especially, this is a picture of my grandfather, and this is my cousin. And my grandfather was diagnosed with dementia, and this was taken when he was 95 years of age. And I heard that it was starting to become quite problematic around his care. And so this is right before I started my job at Sinai. I was able to fly over to India and go spend time with him. It was the last time I ever got to see him, and it was an incredibly special time we had together. But his care was becoming problematic because he had all these challenges with dementia. The ironic thing is he lived with 4 other doctors, but they didn't know what dementia was. Again, geriatrics in India is a very new specialty, and they didn't know actually how to provide care. And you can provide care in a number of innovative ways to a person with dementia, even though there's no cure. And that was perhaps one of the greatest things, was how useful I could be to my own family member, as a geriatrician. And one of the reasons why I'm so proud to do that, because if the only thing I could do is help my grandfather, then all of this journey was worthwhile when I had that first conversation with Dr. Webster 15 years ago. So I'm going to stop there, and we might have a few minutes for questions.
So my question was just regarding your thoughts on the changing field of geriatrics. Certainly in Australia, geriatrics is just applied to medicine, basically, over 65-year-olds. How do you think that landscape's going to change, especially as the population ages is older for longer? Do you think it'll be more subspecialised, or how will it pan out?
Yeah, so I think, this is the interesting story when you actually think about pediatrics versus geriatrics. Because, when people want to reference, they're like, you're a geriatrician, and I've never really met one of you before. And I said, well, in Canada, we only have 250 geriatricians out of 75,000 doctors, right? We have 10 times the number of pediatricians, right? So it just gives you a scale of how small we are in numbers. But then when you think about specialties like pediatrics, it's my, best comparative, specialty, because there's many more similarities between pediatrics and geriatrics, I think, than most other specialties, is you start realizing that there is subspecialization that's occurring. In our program, in our geriatrics program, we're the biggest program in Toronto now, and not only do we do general geriatrics, but we offer a number of subspecialty activities now. We actually have a fellowship in geriatric nephrology. We have a fellowship training program in geriatric emergency medicine. We also have another fellowship in geriatric oncology. And this is where actually you're starting to see that you can actually see a lot more subspecialization happening when you think about the issues of cancer and older adults. And again, the different approaches you need to think about in that environment versus being more of a generalist person who would see that. So I think as the specialty is maturing, as it's growing, a lot of these specialties like orthogeriatrics was a novel concept. It's now a standard of practice within the British NHS and in Australia. You see a lot of these models, but we were one of the first hospitals in the country to bring the orthogeriatric model to Canada, right? Still very, very young in that area, but I think that's where I see the future of geriatric care going. Where we start looking at these issues, not just clinically, but also thinking about planning for services, planning for care, and being more involved. So one of the things we were able to do through our strategic work is change the way we pay geriatricians in Ontario, so that not only are we paying them to do clinical activities, but things we call capacity building. How are we actually making sure that we democratize education? Because there's never going to be enough geriatricians to provide all the care that Ontarians and Canadians need. So how do we make sure that other folks actually have the training? And how do we actually impart those knowledge and skills so that things like groups like paramedics, for example, can be more actively involved in doing things that are geriatric oriented as well? Got a question over here.
Thank you very much. I was wondering if you could speak a little bit more about how the ACE strategy actually got started, because I think often as clinicians sometimes it's easy to focus on the day-to-day and not necessarily engage critically with the process of the day-to-day. So who was on the team, where did the funding come from, that sort of thing.
Absolutely. So, I think if you have a big idea, right? Like if you say that, because a lot of the work that I had done during my fellowship in Baltimore was this idea of the elder-friendly hospital. The idea that there's lots of evidence that's actually been created in all these journals about this initiative, that initiative. And you saw all around that circle, there were a whole bunch of individual initiatives done. Those all have New England Journal of Medicine papers or other papers around them. Most, like all of them, I had nothing to actually do with writing, which was great. New models, I'm actually participating in doing that work. But again, there's a lot of this work behind there. And so part of what I wanted to do was, when I was starting to think about starting my career, that I really want to make my focus models of care in geriatrics and do this, especially when there were so few areas where people are actually thinking about geriatrics, in Canada. I want to find an organization where I could land that actually was ready for this change, right? And that meant that I had a CEO and a board that actually said, we actually value geriatrics and we will make this part of our strategy. But it also meant that I had frontline partners in crime, pharmacists, social workers, nurses, who didn't want to just do the day-to-day clinical work, but actually come together and say, we meet actually once a month for an hour and a half. We have what we call our geriatric steering committee that's been meeting the same Wednesday every single month for the last 6 years now. And we get together and we share our ideas. We bring literature together. We say, this is kind of what I've read about. Have you read about this? And how can we implement it? And it was everything, not just thinking about clinicians, right? Because it's one thing if you have clinicians, around the room saying, we want to do this. But clinicians work in bureaucratic environments, right? We work in a hospital that has managers, a CEO, has a board, has priorities and everything. So what we also did is make sure that management was part of the team, right? So I had a management role as well, but we had other managers involved, so they could say, well, this is actually going to be a fundamental change to nursing practice. Therefore, if we want to do this, how do we get nursing leadership on board, if you will? The other key thing was IT. Because when we start thinking about how do you enable innovation, right? When we think about innovation, people think about IT, genomics, these sorts of things. But a lot of the basic things we wanted to do were really, really, really basic, right? And the key is that in our hospital, we collect data every day in our electronic health record, but we never actually reproduce it in ways that can actually be represented to us in ways that can give risk screens and other things that can help us do our work better. So one of the great pieces of advice that a mentor also gave me was make sure IT's around the table. Get them excited. Ask them if they want their, do they have parents who are not receiving good care either? And, how do they want to be a part of this change? So these are kind of the people that we had around the table. Again, it was all these folks where they were saying what's in it for them, right? And that. But one of the things we did to keep everybody engaged was we go after awards as well, right? So again, I say it's not about me, it's about us, right? But we've gone after awards. And I remember the IT team became our best friends when we won them it was actually called the ACE Award too, Advancing Clinical Excellence. Everyone loves this term ACE, but we won this big IT award, and it was our IT team that got a big award for changing the electronic health record and doing other basic IT innovations, which were nothing super special, but they were those things that actually enabled the work that we do to make us more efficient and actually using technology to enabling what we could actually do differently. So I think those are the things where you want to think about, what is the change I want to do? Who do I need to help me out? Because if I didn't do this in partnership with nursing, I would have been nowhere, right? If I didn't do this with IT, we wouldn't be as efficient as we are today. So think about who are those people you need, and then sell them on what's in it for them. Agnes, we'll get you on mic.
Thank you. What about task shifting and create a multitude of, there are so many people jobless with a big hat, and create an army of community health workers for elderly that keep them home when they are sick. It avoids them to lose their capabilities and keep them home longer and happier and less confused.
Yeah. So the question is, what about engaging people beyond clinicians, right? The traditional clinicians, thinking about people within the community and other sectors.
Non-clinician.
Exactly. And that's been a huge focus of ours as well. The biggest group that we focus on is family caregivers, right? Especially for our patients who live with dementia. For example, 98% of the folks who receive home care, in Ontario and Canada actually have a family caregiver involved as well. So we got a donation and we started a center where we actually train caregivers to learn about dementia, to understand all the different issues that can happen, but we also get them to work with standardized patients, actors who can act out things that can happen with the demented patient so that they actually feel empowered and ready. Because the literature shows if a caregiver is better empowered, if folks in the community, in their neighborhood are actually better empowered to work with them, they're more likely to actually not reach a crisis situation where they then say, forget it, just send them off to a nursing home. The goal is that if we can actually empower folks more towards the community, more towards the front line, then that's kind of what we're working on. We also do a lot of outreach work in Northern First Nations communities where we've actually set up outreach geriatric clinics. So I do this along the James Bay coast of the Hudson's Bay. And that was very much a community-driven model, where we really worked with the communities to actually create a model that they wanted, that they would actually own. But when we fly in twice a year to these communities to do geriatric assessments and support the folks to bring in the expertise that can't live in the community, what we do is our clinics are already pre-populated by patients that the community has chosen themselves. But in order to choose the right older people to be seen, they have to know what are the issues to look for, how they can support the maintenance, how they can do that work as well. So I agree with you completely. The fact is, especially when we start thinking about geriatric models of care, not just in rich countries like Canada, but in other countries where we have a shortage of healthcare workers, how do you start engaging the public? How do you start engaging other folks to actually work on those issues too?
Yeah. We start in Rwanda the first cohort is going to be out now and start to work next month. We train them 4 months with the Minister of Education on palliative care and chronic disease, and I know that elderly people will fail in their portfolio. Mm-hmm. We give them a bicycle and a bag, and 4 villagers, a man and a woman, and they will go house by house and provide care. And we hope that it will bring more human care, and that it will allow us to build less hospitals.
Yeah. And so the final thing I just want to say is that with so much of the work we do in geriatrics, it's just making sure that people have that basic knowledge. When I went to see my grandfather, the big intervention I did was I actually sat down with my aunt, who was the primary caregiver, and educated her about dementia, talked about his issues with incontinence and other things, and said, if you just do these things a little bit differently, that actually takes the problems away. And she was so grateful because there wasn't any fancy technology. There was no sequencing of the genome for this, right? And I'm not saying anything negative about that, right? I'm just saying that the fundamental part is that our society has never dealt with such an aging population before. So a lot of these concepts that we are going to be living with are foreign concepts to us. So it's just the power of some education, how much that can actually make an enormous difference in terms of the way we approach the care of each other and how we think about, our lives as we age too. I'm going to shut up there.